Premenstrual syndrome, or PMS, describes a constellation of recurrent symptoms that occur during the luteal phase, or last half, of the menstrual cycle and usually resolve with the onset of menstruation. The American College of Obstetrics and Gynecologists defines premenstrual syndrome as the cyclic occurrence of symptoms that are sufficiently severe enough to interfere with some aspect of life and that appear with a consistent and predictable relationship to menses. A woman experiencing PMS may have a wide variety of seemingly unrelated symptoms. For that reason, it is difficult to define and more challenging to diagnose PMS. PMS affects millions of women during their reproductive years. Up to 75% of menstruating women report on having one or more premenstrual symptoms, and up to 10% report disabling, incapacitating symptoms. The exact cause of PMS is not known. It is thought to be related to the interaction between hormonal events and neurotransmitter function, specifically serotonin. Not all women respond to serotonin reuptake inhibitors, or SSRIs, which implies that there may be other mechanisms involved as well. According to the American Psychiatric Association, premenstrual dysmorphic disorder, or PMDD, is a more severe variant of PMS, affecting between 3 and 6% of premenopausal women. Experts compare the difference between PMS and PMDD to the difference between a mild tension headache and a migraine. PMDD markedly interferes with work, school, social activities, and relationships with others. Treatment of PMS is often frustrating for both clients and healthcare providers. Clinical outcomes can be expected to improve as a result of recent consensus on the diagnostic criteria for PMS and PMDD. The management of PMS or PMDD requires a multidimensional approach because these conditions are not likely to have a single cause, and they appear to affect multiple systems within a woman's body. Therefore, they are not likely to be amenable to treatment with a single therapy. To reduce the negative impact of premenstrual disorders on a woman's life, education, along with reassurance and anticipatory guidance, is needed for women to feel that they have some control over this condition. Therapeutic interventions for both PMS and PMDD address the symptoms because the exact cause of the condition is still unknown. Treatments may include vitamin supplements, dietary changes, exercise, lifestyle changes, and medications. The medications used in treating PMDD include antidepressants and anti-anxiety drugs, along with diuretics, anti-inflammatory medications, pain relievers or analgesics, synthetic androgen agents, oral contraceptives, or gonadotropin-releasing hormone agonists. Here are some treatment options for PMS and PMDD. The first category are lifestyle changes. Reduce stress. Exercise 3 to 5 times each week. Eat a balanced diet and increase water intake. Decrease caffeine intake. Stop smoking if you do, and limit the intake of alcohol. And attend PMS or women's support groups. There are also vitamin and mineral supplements which may help, including a daily multivitamin, vitamin E at 400 units daily, calcium at 1200 milligrams daily, and magnesium at a dose of between 200 and 400 milligrams daily. Medications that can be used include NSAIDs, or pain relievers that are taken a week prior to menses, a low-dose oral contraceptives, or antidepressants, also known as SSRIs. Anxiolytics, which are taken during the luteal phase of the menstrual cycle, diuretics to remove excess fluid, progestins, gonadotropin-releasing hormone agonists, and danazol, which is an androgen hormone which inhibits estrogen production. No single treatment is universally recognized as effective, and many clients often turn to therapeutic approaches outside of conventional medicine. Many women use dietary supplements or herbal remedies for their menstrual health and treating their bleeding disorders, although there has been little research to demonstrate their efficacy. Alternative therapies include the use of calcium carbonate, magnesium, vitamin B6, evening primrose oil, Vitex agnus cactus, ginkgo biloba, viburnum, dandelion, stinging nettle, chaste tree berry, burdock, raspberry leaf, skullcap, and St. John's wort. Although research has not validated the efficacy of these alternative therapies, it is important for the nurse to be aware of the alternative products that women may choose to use. In PMDD, the main symptoms are mood disorders such as depression, anxiety, tension, and persistent anger or irritability. Physical symptoms such as headache, joint and muscle pain, lack of energy, bloating, and breast tenderness are also present. It is estimated that up to 75% of reproductive age women experience premenstrual symptoms that meet the criteria for PMS, and up to 10% meet the diagnostic criteria for PMDD. According to the American Psychiatric Association, a woman must have at least 5 of the typical symptoms to be diagnosed with PMDD. These must occur during the week before and a few days after the onset of menstruation, and must include 1 or more of the first 4 symptoms, as follows. Affective liability, including sadness, tearfulness, or irritability, anxiety and tension, persistent or marked anger or irritability, depressed mood or feelings of hopelessness, difficulty concentrating, sleep difficulties, an increase or decreased appetite, an increase or decrease in sexual desire, chronic fatigue, headache, constipation or diarrhea, or breast swelling and tenderness. Thank you for watching.